Hi everyone, here is for SIU live interviews to the legends of urology. I'm Domenico Veneziano and we are here with a true legend of urology, Clayman. Clayman is the one who conducted the first laparoscopic radical nephrectomy. He's author of over 400 manuscripts. He is owner of 14 surgical patents, former dean, and now distinguished professor at the University of California, Irvine. Definitely a great educator and a leader. So, Professor Clayman, let's go back to that 1990. How was the feeling on that table to shape the future of medicine? Let's give us some sensation.
They talk about being in a zone, and when you're in a zone, you're not cognizant of time passing. That first laparoscopic nephrectomy, I think myself, Lou Cavusi, who was right there from the very start, we were in a zone. I don't think we even realized how time was passing. Everything was so in the moment, from the beginning to the end of that procedure, that even at the end of the procedure, there was no realization of what had been done. There was only, okay, now we have to close these port sites. Now we have to get this person off the table. The only one who really, I think, had an inkling of what had happened was Nat Soper, who's now chairman of surgery at Northwestern, who helped us during the initial parts of the case, and then after we were getting sacking and morcellating the kidney, was able to scrub out. And when the sac came out and the kidney was gone, he was audibly, because I have a tape of it, ecstatic. But Lou and I were just in the moment, 100% in the moment.
It was just another surgery, let's say.
No. It was different. Because you really did not know what the next steps were. Because this was so different from doing the nephrectomy in the pig, where the Gerota's fascia in the pig is medial to the kidney, not lateral. So you don't have to mobilize Gerota's fascia in the pig. The kidney, there's no perirenal fat. It's just sitting there. Yeah. And transferring that to the human situation was a huge leap that we did not appreciate until we were actually there in the surgery. In retrospect, it would have been wonderful if we had done 6 or 7 of these in a cadaver. But we didn't realize that, didn't appreciate that, and there we were with an 84-year-old woman on the table trying to do this laparoscopically with equipment and camera systems that today you would look at and go, well, this is not tenable. You know, our only dissecting instrument was a hook electrode. The cameras were the old types of cameras and stuff. And the difficulty in mobilizing the line of Tolt and reflecting it and dealing with the vessels was just, being literally discovered as we were moving along through it. Had we not put up a ureteral stent, we would have probably had to abort the procedure. But with the ureteral stent, we could continue to follow up to the kidney. And again, we did not take the main renal artery. We took 5 separate segmental renal arteries. That's how high into the kidney we were, because we were so concerned about the cava. And we were literally working under the colon for much of the procedure. Underneath,
incredible,
if you will, the colon that had been sort of reflected. It took us a while to figure out how this should be approached. And again, in retrospect, all of that was quote unquote figured out.
Yeah, it's incredible because it sounds like...
I'm sorry, it was all figured out in during surgeries.
So your story lets me think back to the very first space travels, and it looks like you were really working with the unknown. It is very exciting, but you also need to be pretty much courageous to do something like that. How surgeries change today, and with more technology, but probably different responsibilities, would you be able to do that again without much prior training or preparation for that?
Well, first of all, surgeons aren't courageous. Patients are courageous. Surgeons are not courageous. Surgeons are risk takers, but they bear very little responsibility for the risk that they're having the patient take. Because if things don't work out well, the patient lives with the failure for the rest of their lives, and the surgeon just goes on. So first of all, this is not about courage or bravery or anything else like that. This is about trying to develop a procedure that would hopefully reduce the overall amount of human suffering. That's what our goal was. We did a poor job of planning for the first human case. When you look back at this, we missed an entire step in the process, which was, all right, it's worked out in the animal. Now let's take it to the cadaver and see what kind of problems arise, troubleshoot those, correct those, and then take them to a patient. We missed that step.
So you think that training right now has a big value? I mean, getting trained
right. So if we had a new procedure that we developed in the lab, we would immediately take it to the cadavers, because at UCI we have an animal lab. We have an entire fresh tissue lab. So we can do this. Now, in our defense, I didn't have a fresh tissue lab at WashU. We just didn't have that. But we have that here at the University of California, Irvine now, and we can easily do that. Be that as it may, things were much simpler in 1990 than they are in 2021. In 1990, quite honestly, we had thought of just going ahead and doing this without even going through the IRB, because laparoscopy had been around forever. Nephrectomy had been around forever, so we were just combining two things that had been there forever. And it was Bill Catalona, to his credit, who said, hey, you need IRB approval, because if this thing goes up in smoke, you and everybody who's in the room with you is going to be in huge trouble. So we were able to get IRB approval to do 2 cases. And that IRB approval came in a week. Now, my university right now, it's not a week. It would be a minimum of a month or more. And it would have to go through 2 committees. Yeah. First, the cancer committee, and then they would have to approve it. And then, after we go through all those approvals, then we have the privileges of submitting it to our IRB that goes through it.
Yeah.
So by the time we would have completed all that, the robot would have been invented. So, and then on top of that, you now have an ethics committee to go through.
Yeah.
And there's all of this stuff in front of you to try and get through, to the point where for many people, they just go, forget about it. Yeah. And progress stops. So that's really the challenge of today. Even for something as simple as a force sensor that we're using to check how much force it takes to put up a ureteral access sheath, doesn't even go in the patient. IRB approval, et cetera, renewals, reports, and everything else. So it's a lot more work to do things. But just because it's a lot more work doesn't give you an excuse as a physician to maintain the status quo and not try to push things forward to the benefit of your patients. You cannot allow the administration and the administrative hassles to prevent you from making progress for humankind. You cannot do that.
So in a moment when innovation seems to be more difficult, but when also technology is coming into our health. So how do you imagine the OR of the future, where also artificial intelligence and Internet of Things are probably coming towards our beds and standing with us, if not taking our place?
Well, they may eventually not quite take your place, but again, your robots will be far more intelligent than they are today, and they'll actually be robots rather than master-slave type of situations where you're set to do a procedure, you get everything lined up, maybe you dissect out the prostate, you've identified the apex of the prostate, you're ready for the anastomosis, the prostate's out, now you press a button, and the robot proceeds to do your anastomosis and put each suture in exactly 2 millimeters behind the cut edge and ties each suture at the same tension as he just goes ahead and does the anastomosis. I think things like that will or can eventually occur. The surgeon will still be there to guide things to some extent, but your role will be almost like a pilot who's on automatic pilot, and you have the ability to take control anytime you see fit. That's way down the line. Closer is the involvement of artificial intelligence and the Internet of Things to integrate the entire operating room. So while you are operating, you are constantly aware of what's going on with the patient and around you. You have a little pop-up screen. You know what the blood pressure is, what the pulse is. You know if all of a sudden the pressure for respirating the patient is going up. You're sensitive to that particular kind of change that might indicate that there's a pneumothorax occurring or something like that. So you are going to have an ability to see and know much more around the patient than you have right now. Everything will get recorded. You'll have an opportunity, if you will, to review everything. I think Dr. Lamon and I think Dr. Cavusi are working on the ability to see everything in the operating room and to be able to review it. So that if indeed there's a problem, what went wrong? How can we prevent this from happening again? But more importantly than this black box, it's going to tell you what went wrong, will be the ability to then educate the OR, the AI in the OR, so it's going and it's watching, and as it's watching, it goes, whoa, this is the same pattern that occurred 4 weeks ago, and the patient did poorly. Stop.
Yeah.
Heads up. You're headed for disaster. Okay? And that's very helpful. Remember, the surgeon is always, if you will, in a nice kind of way, suck-faced into the case. Totally committed. Should be. Such that at times it's difficult for the surgeon to see some problem that may be going on outside the field or around him or her. And that knowledge only comes from other people in the operating room being empowered and encouraged to speak up if they see something that doesn't look right. So we start every case. We do the timeout. But at the end of the timeout, I always say, please, during this case, if you see something that doesn't look right or seem right, ask the question, and we will stop and answer your question. Because no one of us is as smart as all of us, and all of us want the patient to do well. Period.
That's great. So it's a kind of a continuous checklist. And of course, being a leader, you need to guide all your team in a correct way. So you also wrote a book about leadership, and you are definitely an expert in leadership. So to close our interview, I would like from you a very short definition of what is being a leader, please.
A leader, in my mind, it's all about servant leadership. The idea that you as leader, your responsibility is to everyone around you. Your responsibility is to empower everyone around you to do better. To realize, as I tell people, my goal for you as a member of, let's say, my team is for you to realize your full potential plus 10%. So that when you're done being on this team and you look back, your impression is, I never thought I could get as far as I got. Your role as a leader is no longer to enhance your reputation or anything else. Your role and success as a leader is totally defined by the people you train, and that's your legacy. Not 400 articles, 500 articles, 1,000 articles published. Not how many awards you've won. That's really pretty meaningless. What is meaningful is after you've checked out of this world, how is this world continuing to change because of the people you trained? That's leadership.
If anyone still had any doubt about the greatness of this man, I mean, thank you so much for being so much inspiring to us. It was really not only a pleasure, but a true honor for me to make this interview. Thank you so much, Professor Ralph Clayman, and hope to see you soon in person after all this pandemic disaster.
Absolutely.
Yeah. Thank you so much. Really.
I'm looking forward to dancing to your wonderful voice and Sticks and Stones. So that's what I'm looking forward to. All right.
Thank you so much.
Dom, take care. Good.
Bye.